Good morning, and welcome to this conference. My gratitude to Professor George Su and the California Thoracic Society for inviting me to speak. I hope you brought your curiosity and your empathy because I am determined to wake up the sleeping giants in all of us when it comes to fighting for our patients living with chronic lung diseases. As we continue the war against the global pandemic, the importance of improving the health and outcomes for asthma and COPD patients has become even more urgent. And achieving control of asthma and COPD is never a bridge too far, so long as we can breathe. This morning, we have a choice: road rage or road kill, where road represents asthma, COPD, and bronchiectasis are all of the above. The key word is reversible, and one word can make all the difference in the patient's fight for breath. We certainly have a choice, but do our patients have a choice in healthcare today? I have this following a slide for disclosure. I hope I can convince all of you at the very end that I am a patient advocate first. I will share my insights on effective team leadership, team core values, and lessons learned from our most valuable assets and greatest teachers. And I'm talking about our patients. We are the vanguard of patient safety. We need the 3 E's. We need empathy, experience, and expertise to build an interdisciplinary population health initiative. We need to see how we can incorporate registered respiratory therapists who can provide value and help patients improve their outcomes. Education is so important, and I will share with you the training tools of our road program at UC Davis to prepare patients for safety at home. And then I will try to again highlight the importance of transitional care and clinics such as a COPD clinic to coordinate the patient's care after hospital discharge. And we'll talk about how important it is to put pulmonary rehabilitation as a centerpiece for your comprehensive COPD program. We need empathy, we need experience, we need expertise in order to help patients like Dorothy. You can feel her despair. We need to recognize that empathy is a choice and it is not an occupational hazard. Oprah said, "Leadership is about empathy." In my opinion, leadership needs empathy. It is about having the ability to relate and to connect with people for the purpose of inspiring and empowering their lives. And as we all know, at the California Thoracic Society and at the American Lung Association, when you can't breathe, nothing else matters. We need empathy and leadership if we're going to promote advocacy, education, through advancement to dispel old ideas and prejudices. For example, COPD is still regarded as an irreversible chronic lung disease. Nothing could be further from the truth. In fact, it's a syndrome. It's underdiagnosed, undertreated. Every 4 minutes, another American dies from COPD. On the other hand, asthma is regarded as a reversible disease. But that is not my experience, particularly when I am in the care of patients who have severe asthma. In fact, severe asthma resembles COPD very much so, and 11 patients with asthma die every day in the United States. So, a lie told often enough becomes the truth. That's a quote from Lenin, the Soviet dictator. And so we're here this morning also, again, to dispel the notion that COPD is irreversible. And I'll show you the proof in due course. The business model for healthcare today incorporates these metrics: quality, cost, and value. But I'd like to alert all of us that you cannot always improve the value of a service by reducing cost. Again, most of the efforts of government, insurance companies, and healthcare institutions have been trying to improve value by reducing costs, but there's a point where you can compromise care and, most importantly, the patient's safety, which is why population health initiatives, such as the one I will share with you today for COPD, for asthma, are very important. And it's centered on really drawing in the patient to improve his or her experience, but most importantly, to protect them. It's all about patient safety. And one of the key words I'd like to share with you again is interdisciplinary. It's a little bit more than multidisciplinary. But through an interdisciplinary program, we can begin to look back on how we care for our patients. Again, health care insurance never guarantees health care. If you look at the metrics that organizations and agencies are using, we're going to focus on exacerbations requiring medications, exacerbations requiring admissions to the hospital, and readmissions within 30 days. We're going to look at the impact on the hospital length of stay and the changes in treatment. But administrators and healthcare institutions do not realize that the secret to the care of the patient is in caring for the patient. And this is what Dr. Francis Peabody said at Boston City Hospital in 1927. And it is a lesson we should never forget. So it's important to have these concepts, these principles in mind, to build an interdisciplinary program for the hospital and clinic to address a clear and present danger in patients with an unmet need for education, safety, and healthcare services. COPD patients are underdiagnosed and undertreated. Asthma patients are overdiagnosed and overtreated. And the irony here is that severe asthma is underdiagnosed and undertreated. Patients have become so indifferent. Many have lost hope, like Dorothy. Many of them also fail to recognize that with discipline, with motivation, they can be part of the remedy. Clinicians with caring experience and expertise are what is needed to make an interdisciplinary program successful. We need doctors, we need nurses, we need registered respiratory therapists, we need pharmacists, we need discharge planners. We need everybody. We need healthcare professionals who understand that empathy is a choice and not an occupational hazard. We want people who are proactive rather than reactive, who want to fight to make a difference. Here is a dilemma that we're faced with virtually every day. Asthma versus COPD. Which is it? I have no idea. Does it matter? I think it's far more important to address the treatable traits in these patients. To know COPD, you have to know asthma. To know asthma, you have to know COPD. But in the end, what we must do is to remember to confirm the diagnosis. This is especially important in asthma, since a third of people with asthma do not have asthma. After confirming the diagnosis of asthma or COPD or both, phenotype the patients, try to endotype the disease mechanism, and have the courage to do a clinical trial of one. Spirometry only detects airflow limitation. We need better biomarkers to help us diagnose COPD and asthma and ACOS, or the overlap syndrome, because there's a lot of overlap. But here's the proof that COPD is reversible. A post-bronchodial increase in FEV1 is common. In fact, It is the rule, not the exception. Even when the FEV1 is low, there is improvement. But as you can see in this table from Gold as well as Gina, reversibility is one of the hallmarks of chronic obstructive lung diseases, what I like to call ROAD. Now, we know there's a lot of dermatology, there's a lot of immunology, there's a lot of neurology in asthma as well as COPD. But what is forgotten is the psychology of asthma, of COPD, and chronic bronchiectasis, which is very important in driving patient adherence, their attitudes, and lifestyle changes. Very importantly, smoking cessation. Our success is rooted on our ability to share information, to educate our patients, to make them more capable of controlling the disease rather than have their asthma or COPD control them. In fact, when it comes to initial therapy for asthma or COPD or for ACOs, it's important, again, to take in all their symptoms, to look at their treatable traits, dyspnea, cough, chest tightness, and wheeze. But this is just the beginning of a journey together with the patient in a partnership toward a better quality of life and safety at home. If a patient has asthma, treat it as asthma. If the patient has ACOs, treat it as asthma first. If the patient has COPD, again, avoid inhaled corticosteroids unless the patient's response warrants it. So initial pharmacologic therapy needs to be reevaluated every 2 to 6 weeks, every couple of months. It's important to assess the patient's response, to review their inhaler technique, and to consider the possibility of referring them to a specialist. But it's very important to remember that this is not a simple process. I tell my patients that I'm the shoe salesman. So if it's asthma, I'm the asthma shoe salesman, and it will take some trial and error to really individualize the patient's treatment plan. Early diagnosis, I think, is what is critical. And it's difficult because we've been told that COPD is irreversible. In fact, by the time they're recognized, often they've experienced an exacerbation or two, or they're hospitalized. And we don't do anything when they're coughing, wheezing. We talk about smoking cessation, but the success rate is still dismal to this very day. Patients are suffering from dyspnea, or what I like to call exercise intolerance. And so there is a delay in the diagnosis of COPD, or for that matter, for severe asthma. So it's very important to recognize this fact that a significant drop in lung function is often required before patients become symptomatic. Chest x-rays, old reliable, is unreliable. And at the California Thoracic Society in 2016, I actually revised one of the, I guess you could say, statements from the GOAD strategy, because I felt that the adjective moderate, as you were aware, we were asked to assess the severity of airflow limitation by looking at the FEV1% predicted. And we're asked to group patients into mild, moderate, severe, and very severe. But I felt that really can hurt patients by delaying our perception of how serious the disease is. And many of you who were there in Monterey, California, remember that instead of mild, moderate, severe, and very severe, I proposed that we call it early, late, too late, and way too late COPD. Do you need a picture? This is way too late COPD, the flow volume loop on the right side. Again, we have lost so many opportunities, and more importantly, time, by not addressing the patient's symptoms earlier. Why is it that we treat asthma patients for their symptoms when their lung function is normal? Why do we have to wait for patients with COPD to lose lung function before we become alarmed? Again, it's a controversial issue that requires much more in-depth discussion. But the patients are also to blame. Patients underrecognize their symptoms. They don't report exacerbations. And again, physicians, advanced practice providers incorrectly diagnose COPD or asthma, attributing it to another disease or to aging. And patients do the same. They may also blame the lack of physical fitness or to continue cigarette smoking. But what is important to understand or to appreciate is that patients with asthma or COPD can adjust readily to their symptoms. They can avoid symptoms by really curtailing their physical and their important social activities. This is why, in addition to talking to patients, it's important to use validated measures such as the asthma control test and a COPD assessment test in patients who have symptoms of shortness of breath, cough, wheezing, and chest tightness. What we did at UC Davis was to integrate, to put together clinical expertise and experience. We searched for clinicians with empathy, with leadership, and most importantly, bedside manner. I will never forget the lesson I learned from Hattie Richardson, a nurse on the GI ward at the Wadsworth VA when I was an intern at UCLA. She told me that if I wanted to become a good doctor one day, I first had to become a great nurse. I never forgot that lesson. Never forgot it. So important. And also, I learned from Hattie how important it is to work together as a team. We need an interdisciplinary attitude, not necessarily multidisciplinary, because people can walk away. We cannot walk away from our patients. We need to be there for them. We need to become a part of their lives. We've relied on GOLD, on GINA, and we relied on the COPD National Action Plan for developing our own education booklets at UC Davis. And we do what you do in your clinical practice. We make certain that their inhaler technique is correct, or we will train them. We check their peak inspiratory flow rates. We write out their action plans. And we employ a checklist to kind of give patients a preview, a menu of what is to come. And I'll go through this checklist, this A, B, C, D, E, F checklist towards the end of this lecture. But it's so important to remember to include Pono Rehabilitation, to tell patients there are resources in the United States such as the COPD Foundation. But to find these patients is not that simple. And so we have employed, particularly for those hospitalized at UC Davis Medical Center, a screening tool, making the EMR work for our patients. And on this slide, you'll see the screening criteria in the left-hand column. We look for patients over age 40, meaning at least 3 of the following criteria, and we include the other. And we can use this not only in the hospital, but also in the clinics to find patients, because the majority of the patients with chronic obstructive airway diseases or ROAD are not on maintenance therapy. They need us. So I'd like to share with you the actual documents that I submitted to the University Medical Center when I developed the ideas for a more comprehensive approach to patient care. And I'd like to just take a moment to read the paragraph, the business objective statement. This is more like a mission statement. The UC Davis Road Center was inspired and born from a need to heighten public awareness of reversible obstructive airway diseases, or ROAD. This initiative will simplify patient education and streamline access to primary and subspecialty services for individuals and families experiencing major difficulties thriving with asthma, COPD, and or bronchiectasis. The vision is that people living with asthma, COPD, and bronchiectasis will have the knowledge and education and healthcare services to live fully and without disease limitation. And the mission is to integrate and provide patient care services for these patients to promote patient education, safety, social networking, and to align our goals with national efforts. Putting patients first led to the Road Center recognition. In fact, definitive healthcare data confirmed UC Davis Health from 2015 to 2020 to be among the lowest readmission ratios, exceeding 80% of the hospitals participating in the hospital readmission reduction program. We also were able to demonstrate the lowest mortality for COPD patients, reaching the 96th percentile. Again, this program under the Affordable Care Act was designed not to provide incentives, but to penalize hospitals to implement strategies to reduce the number of costly and unnecessary hospital readmissions, not only for COPD, but for other diseases as well. I am so proud to tell you that UC Davis has achieved their 5th wreath for high performance in COPD care. You can do the same. It requires, again, assembling healthcare professionals who care, but most importantly, to find the patients. Our patients are our most important assets. They're the ones that benefit, and they are the ones who create these outcomes that you will see in the next slide. Again, at UC Davis Medical Center, the majority of the patients who had COPD exacerbation had GOAT 3, severe or too late COPD. 25% had GOAT 4, or very severe or way too late COPD. And only 15% had moderate or late COPD. The majority were women. We were able to capture the majority using the EMR screening tool. We found that 65% of the cases were on maintenance therapy, but over 90% did not use their inhalers properly. A third were on home oxygen, and only 10% completed Pono Rehabilitation. Our program of patient education and patient safety begins the very first day patients are hospitalized for COPD exacerbation. We have a curriculum spanning 3 or 4 days, depending on the ability of the patients to take in the knowledge. We, again, coordinate the patient's care in the hospital, and we help with hospital discharge and transitional care. I thought that we would lengthen the hospital stay because our hospital length of stay was 7.6 days. But to my shock, the ROAD program reduced the hospital length of stay by over 2 days. We reduced the 30-day hospital readmissions rate from 16 to 6%, and we've done so for the past 5 years consecutively. Importantly, patients have improved their quality of life, and this is what I'm most proud of. We were able to successfully get 21% of our patients with COPD to stop smoking. Sadly, I was most disappointed that only 11% of patients went to Pono Rehabilitation, although every one of them were introduced. But we could not achieve these outcomes without our patients, and we could not achieve what we did without registered respiratory therapists. This is a group photograph from 1996, and this is where we launched our UCAM program, the UC Davis Asthma Network. We did it with respiratory therapists in a new role. Here is a photo of all our COPD case managers, and in the center is Patricia Brown, who is my department manager in the Department of Respiratory Care. This is from 2012. Respiratory therapists have a vital role in the hospital and a even more vital role in the clinics. Why respiratory therapists? I'll ask you, my colleagues, my peers, why not? I had to do the big sell to the University Medical Center back in 2011. I had to meet with Carol Robinson, who was the UC Davis Director of Nursing and Chief Patient Care Services Officer for UC Davis Medical Center. I went there with Pat Brown, and the first question Carol asked me was, why not a nurse practitioner? This is where I remembered what General Douglas MacArthur said. You will be remembered for the rules you break. I also remembered what Voltaire said. When it is a question of money, everyone has the same religion. I argued that respiratory therapists are the best, the most qualified healthcare professionals for the Road COPD program. For the salary of one nurse practitioner, 2 respiratory therapists can be trained to become COPD case managers. And I personally trained the case managers. What you see on the slide is the annual salaries of important healthcare professionals in the United States and in the state of California, though I would quibble with the hospital's CEO. I had to argue with Carol that a successful COPD program will also create nursing jobs, which I did. And I argued that the ROAD program will complement other programs, such as the Delivery System Reform Incentive Payment Program, or DSRIP, that the University Medical Center was involved in. We basically have seen an evolution in the way we can provide care. I think we need to understand how important it is to be multidisciplinary and interdisciplinary, and to reach out to where the experience and expertise lies. The guidelines that have been published are dangerous to patients if we prescribe and forget. Again, the guidelines also oversimplify. It is never too late to care. We need to fight indifference, to fight the pride and prejudice that goes with people with chronic lung diseases, including asthma and COPD. I want us to be the difference, to promote public awareness, to promote smoking cessation, to remember that patients need to know what's coming next, which is why we developed this ABCDE checklist tool, which has been included in the toolbox at the COPD Foundation. So what does A stand for? Anticholinergics, antibiotics if you deem them necessary. B stands for beta-2 agonists, long-acting and short-acting. As we know now, not only from our own clinical experience, but the American Thoracic Society came out in May 2020 with a strong recommendation that patients with COPD, if you think about initiating initial therapy, they recommend a combination of a long-acting muscarinic receptor blocker together with a long-acting beta-2 agonist over a LAMA alone and a LABA alone. C stands for inhaled corticosteroids, not prednisone, D stands for Daliresp or roflumilast, and E stands for education, exercise, and your empathy. F stands for family, friends, and flu vaccination, and will have to include the vaccine against the COVID-19 coronavirus next year. For asthma, you just have to change the order of A, B, C, D, E, and F to CBA. So it's inhaled corticosteroids, but you must all appreciate that they work only in about 60 to 65% of patients. So it's important to reassess the patient's asthma control test score. B stands for beta agonist, never to be used alone in the United States. A stands for anti-leukotriene drugs, as well as anticholinergics. And I guess B also should include biologics. But D, roflumilast, not approved for asthma. E, again, and F are the same. And with this, patients can come and join the fight, become the most important player in the quest to control and to reduce symptoms and the risk for exacerbations. But Pono Rehabilitation cannot be forgotten. Why are these people smiling? They're smiling because they have finally wrested control of their life away from COPD or asthma or bronchiectasis or all the above. And they did it with the help of people like you with empathy, experience, and expertise. Pono Rehabilitation and the ROAD program became the detour that these wonderful people needed to get back on track, to get back into the human race. We help these patients rediscover their pride and their purpose in life, their self-esteem. And when we do that, we renew ours as well. We launched the UC Davis Pono Rehabilitation Program in 1994, not for COPD. We launched it for the lung transplant program. The lung transplant program no longer exists at UC Davis, but the COPD patients and the Pono Rehabilitation program endures because they need it. They love it. Looking back, I have to ask myself, was it profits before patients? And what was the integrity of the intent at the time? They were not concerned about our patients with COPD. They were concerned about patients receiving lung transplants and the need to meet criteria to be a center. Remember Dorothy? Remember you felt her despair? 6 weeks later, this is Dorothy, smiling. She was 66 years old at the time. A lot of people thought she died in the interim. I showed them this photo of Dorothy with her husband Bill celebrating Dorothy's 81st birthday. This is what we are all capable of doing for our patients by fighting, in many instances, our own indifference. General Douglas MacArthur said, a true leader, and I like to interject a true team leader, has the confidence to stand alone, the courage to make tough decisions, and the compassion to listen to the needs of others. He does not set out to be a leader, but becomes one by the equality of his or her actions and the integrity of his or her intent. Patients are not fools. They know when you are genuine. We need to remember what Robin Williams said as Dr. Hunter Patch Adams, that death is not the enemy, ladies and gentlemen. If we are going to fight a disease, let us fight one of the most terrible diseases of all, indifference. So we have a choice as we conclude this lecture, road rage or roadkill. The choice is yours. We need to protect our patients. Thank you for listening. to this lecture. Keep well.